Hello friends, my name is Dr. Saf and today we are going to talk about ARDS, acute respiratory distress syndrome. So as we know, ARDS is a life-threatening form of respiratory failure due to diffuse lung inflammation characterized by hypoxaemia, bilateral infiltrates and non-cardiogenic pulmonary edema. It is important for us because it carries high mortality. Up to 40% patient may die despite advances in care. So regarding the definitions of ARDS have evolved since the first description of this syndrome in 1967 by Ashbach. Then came in 1994 AECC definition, or which is also known as American European Consensus Conference definition. So this definition was proposed in a conference and this was used in several successful clinical trials. Between 1994 till 2012, it has been used in various clinical trials including those of lung protective ventilation, prone positioning and fluid conservative management strategy. So very big trials use this AECC definition. The Berlin definition of ARDS simplified the terminology. It clarified several criteria and provided validated support for three strata of initial arterial hypoxemia. So it categorized the hypoxemia into mild, moderate and severe categories which correlated with the mortality. The first criteria is the timing. So they recognized the acute onset and they gave you cutoff of the acuteness. So they gave you 7 days of cutoff. So there should be an insult and following within 7 days of that insult there should be bilateral infiltrates. Okay, the ARDS should develop. If it is more than 7 days, that will not be ARDS. Imaging wise, they said either chest x-ray or CT scan of chest should be used to look for the opacities, and the opacities should be bilateral opacities, homogeneous bilateral opacities or infiltrates. Then the third criteria is the origin of edema. So they said that origin should not be fully explained by the cardiac failure or fluid overload, and for that they gave the fixed parameter. They said we can use echocardiography or PaO2 or PCWP to rule out the cardiogenic pulmonary edema. And the fourth criteria, they said oxygenation. The parameter which they gave was PF ratio or PaO2 upon FiO2 ratio. And then they categorized the ARDS into three severity: mild, moderate and severe ARDS depending upon the PF ratio ranges. This oxygenation should be defined only after application of PEEP. At least should be more than 5 centimeter of water, or CPAP more than 5 centimeter of water. So advantages of Berlin definition is very important. They might ask you in exam. So Berlin definition improved upon the American European Consensus Conference definition in several key ways, making it more clinically useful and research relevant, and it removed many confusions, ambiguities. It gave you clearer timing of onset first of all. So because in ACC the timing was vague, acute onset was not properly defined. In Berlin definition it was defined as within 7 days of known clinical insult or cause. So it reduced the ambiguity in diagnosis. The second advantage is the better oxygenation criteria. In ACC there was no PEEP requirement for the definition, but in Berlin they said and they required PEEP should be more than 5 centimeter of water. So it avoids the misclassification of hypoxemia due to low PEEP. Suppose the patient who has low PEEP of about 2 centimeter or no PEEP at all and having at present a PF ratio of 180. So the moment you apply PEEP of 5, your PF ratio will change and it can go more than 200. So the moderate ARDS can become mild ARDS with the application of PEEP. Okay, so this has to be set, and in Berlin definition it was set more than 5 centimeter of PEEP. However, again you can say that 5 and 10 and more than 10 there may be differences in the oxygenation. So again it has to be challenged or modified in the further definitions. Anyway, at least this much they gave you in Berlin definition. And one more thing they did for the oxygenation was that they gave the severity classification mild, moderate, and severe, as you know, because it predicts the outcome, the mortality. So for mild, the mortality is 27%, moderate it is a little higher, and for the severe it is about 45 to 50% of mortality. Then the third important advantage is the improved imaging criteria. In ACC definition, they said only chest X-ray is enough for bilateral infiltrates, but in Berlin they allowed CT scan for defining bilateral opicities. So it accounts for modern imaging practices. The fourth important advantage was that it excludes the cardiogenic edema explicitly. It requires an objective assessment, for example, echocardiography, to exclude the cardiogenic pulmonary edema. So it reduces the false positive ARDS diagnosis. Now, the fifth important advantage is that it removes the term ALI, which was used by ACC. So this in ACC definition, the mild ARDS was ALI, So there was no term called mild ARDS, but PF ratio less than 300 was called ALI at that point of time, during those times, and ARDS was only term when PF ratio was less than 200. In Berlin, they dropped ALI and focused only on ARDS with severity stratification. So it simplified the classification and avoids many confusion among researchers and clinicians. The sixth criteria is this six advantages: the better correlation with the mortality. As I said, mild ARDS can portend the mortality of 27%, moderate can correlate with the 32% of mortality in patients, and severe ARDS can go up to 45% of mortality. So more predictive than ACC binary classification. Why Berlin is better? Berlin definition is basically more precise, clinically relevant, research relevant, and evidence-based, making it the gold standard for ARDS diagnosis today. Okay, so again there are differences from ACC classification, ACC definition, as can be seen in this table very clearly. But there are some limitations. So while the Berlin definition is the current gold standard for diagnosis of ARDS, it has several important limitations that affect clinical practice and research. First important limitation is that it requires invasive mechanical ventilation. PEEP should be more than 5 cm of water for diagnosis. But anyway, patient may be on HFNC or an IV sometimes, okay, especially when we have seen many patients during COVID-19 time that they were managed, especially the early ARDS patient, the mild ARDS patients were managed with HFNC or an IV. So after advent of use of HFNC and IV, which has been popularized in last 10 years, it is very difficult to apply Berlin definition in those patients, because Berlin definition requires PEEP criteria. Okay, so exclusion of non-intubated patients, this is the first and foremost limitation. It completely forgets the patients who can be managed on an IV or HFNC. What about those people? So they will not be called as ARDS. That's the main limitation. Second limitation, reliance on PF ratio. So you need to do a PaO2, means for PaO2 you require an arterial blood gas analysis. Okay, so unless you have ABG, you cannot calculate the PaO2 FiO2 ratio. So that is one more important limitation. So it requires invasive testing. And many ARDS patients, especially the early ARDS patient, do not require arterial lines. So it is a very invasive thing, and in resource limited setting when ABG machines are not available, for example, the patient who is in Africa, South Africa, or the patient in China, remote places, any patient in the remote place may not have ABG access. So in such patients it is difficult to categorize based on PF ratio. Third important limitation, that it requires the imaging, especially the CT scan and chest X-ray to detect the ARDS. So it may misinfiltrate. Chest X-ray misinfiltrates in early stages, and CT sometimes not available. So these are limitations. So in unstable patient you cannot do CT even. So relying solely on chest X-ray or CT can potentially lead to delayed or misdiagnosis of ARDS. So the recent recommendation is to use the ultrasound to check B lines. If there are bilateral B lines, then you can pick up ARDS, early. Again, last fourth important interesting limitation of Berlin definition is that biomarkers have not been incorporated in this definition. So we have two phenotypes of ARDS: hyperinflammatory and hypoinflammatory ARDS, as per the recent papers. So two phenotypes have different outcomes, and they need absolutely different type of therapies, and they have different outcomes, mortality, and they require biomarkers such as IL-6 and angiopoietin-2, which could guide the treatment. But in the Berlin definition, there is no discussion about the subphenotypes or biomarkers. Again, there is no the fifth limitation of ARDS, that there is no pediatric consideration. It was only proposed for adult. And kids also can develop ARDS. We know ARDS and all, so can develop in the pediatric population. So for those patients, we don't have any definition. Then last is crucial limitation is that it may miss late onset ARDS, which may occur after 7 days of primary insults. In some cases, like post-operative ARDS, which can occur even after 10 days. So 7 days limit can miss the diagnosis of late ARDS. That's one more important limitation. In 2021, Mathe et al. Published a viewpoint in Lancet Respiratory Medicine 2021 paper to expand the definition of ARDS to include the patients treated with high flow nasal oxygen of at least 30 liters per minute who fulfill the criteria of Berlin definition of ARDS. So this is after COVID-19. However, Berlin definition was validated for invasive ventilation. The changing criteria could affect the research comparability, and therefore 2023 ESICM guidelines suggest considering HFNO or an IV patient for ARDS diagnosis if they meet other Berlin criteria. So they should be included. In 2016, Revilio et al. Proposed a very unique kind of ARDS definition, which is known as Kigali version or Kigali criteria of ARDS through research, which removed the requirement of PEEP based on Berlin definition and replaced PaO2 FiO2 ratio with SpO2 FiO2 ratio. So the patients who do not have ABG access, or in whom we cannot obtain arterial samples, in those patients also you can basically detect, diagnose or define ARDS based on SpO2 FiO2 ratio, and there is no need for PEEP. So it removed the PEEP criteria. Lung ultrasound also can be used as per this Kigali criteria, which improves the sensitivity over chest X-ray for detecting ARDS in patients who cannot be transferred to CT scan room. So when to use Kigali definition? In low resource hospital where you cannot do ABG, and in early ARDS on HFNC where there is no PEEP, okay, or the patients who are on NIV, you can use Kigali classification. Well, for today, thank you so much for the attention. I think in 15 minutes you must have grasped the defining criteria of ARDS. I think you will not miss this note. Important facts regarding the definition of ARDS in your exam. Definitely you will be able to speak something in exam, in YY and all.